Good afternoon, everyone. Welcome to today's session from the Central Illinois chapter of ACHE. My name is Jennifer Connelly, and I'm representing the ACHE National Office, and we're thrilled to have you with us here today. Before we get started, I did just want to make a couple of housekeeping notes. For the purposes of noise control, you are all on mute. So as the session progresses, if you have any questions or comments, please feel free to use the chat feature and write those questions for adding to the dialogue. If you are on the go during this session and using a phone or an iPad, feel free to use the Zoom app. Just be sure to log in with the same name that you've registered for this course with so that we can match up your credits. Speaking of credits, you will be earning 1.5 hours of face-to-face credit for today's session. As long as you attend for at least 60 minutes, you will earn that full 1.5 hours. This session is being recorded and will be available within 48 hours by going back into your My ACHE page under the My Online Learning section. So with that, I'm now going to turn the floor over to Lexie Schwartz. Lexie.
Good afternoon, everyone. Thank you for joining the Central Illinois chapter of ACHE for our event today on telemedicine and the healthcare delivery system. Telemedicine has become a healthcare access imperative, and its innovative benefits are of vital interest amid the implementation of most healthcare regulations. Telemedicine uses a variety of forms of electronic communication technology to provide a convenient method to deliver healthcare services and education. This program will survey current uses and organizational deployment of telemedicine, and the discussion includes adoption and innovation across clinical and patient perspective. Technical, operational, regulatory, and financial and reimbursement aspects of the development of telemedicine programs will be investigated. The expanding role that telemedicine holds in daily medicine and its direction into the future of healthcare delivery system will be explored. Our moderator for today's event is Laura Messined, Vice President of Telehealth at Amita Health. Laura is a dynamic nursing leader in the healthcare industry. Her innovative nursing leadership skills enable her to successfully align corporate strategic goals to operationalize clinical and financial targets. She has extensive clinical experience managing diverse groups of professionals within the critical care environment. With over a decade of experience within the telemedicine industry, Laura has proven successes implementing telehealth solutions to drive performance and financial metrics. In addition, she has diverse management experience across the continuum of care, designing, developing, and implementing processes to meet organizational objectives. Laura speaks nationally on a variety of topics. She is a member of the American Association of Critical Care Nurses, Society of Critical Care Medicine, the American Telemedicine Association, Healthcare Information and Management Systems Society, and sits on various professional advisory boards. Thanks so much for agreeing to moderate for us today. Laura, I'm going to pass it on to you.
Thank you, Lexie. Well, welcome everyone. Good afternoon. I'm honored to introduce my panelists that are on today. I'd like to introduce you to Akil Khan, who has his MHA. He has been working in the healthcare sector since 2015. He started as a procure-to-pay consultant for East Coast Health Systems before joining the management team at Catherine Shaw Bethia Hospital. As an ASQ Six Sigma Black Belt, Akil implemented a system-wide EMR and optimized workflows to benefit the care team and the patient. He currently serves as the manager of corporate health services and leads KSB's telehealth program. He also oversees 2 federal grants with over $1 million in funding. His passion is around bringing technology and new solutions to rural hospitals so they better serve their communities. And then I'd like to introduce Desmond Watt. Desmond Watt is a PAC, has practiced in the virtual care for over 6 years with One Medical. One Medical is a national independent primary care organization. As a virtual medical director, he has spent a significant portion of that time in virtual care design, delivery, and workflow optimization. He is a passionate advocate for the importance of telemedicine as an important component of a broader local and national healthcare strategy, and a major piece in addressing the goals of the healthcare quadruple aim. Desmond is a co-founder of a nonprofit physician assistant telemedicine advocacy organization called PAs in Virtual Medicine and Telemedicine. And he is the immediate past president of the executive board. He regularly advocates for the PA role in virtual care as a critical part of our healthcare future, and believes strongly that PAs must take a leadership position within the rapidly growing virtual care space. During his tenure as PA VMT board president, Desmond has spoken to large audience of PAs and other healthcare professionals, as well as healthcare executives, PA program faculty, and students regarding telemedicine and PA advocacy and leadership within this field of care. He is also former chair of the AAPA Ad Hoc Committee on PAs and Telemedicine, under the board of directors of AAPA, led by President David Midman. Desmond makes his home in the suburbs of Chicago, Illinois, and is a 2012 graduate of the Midwestern University Downer Grove PA program. We're honored to have both of them here to speak today. So as one additional housekeeping item, we want to make this session very interactive. So please feel free at any point in time to put any comments in the chat feature. So we're going to start off with the first question, and I'm going to direct that to Akil. In what settings and for which types of patients have you used telemedicine services?
Good afternoon, everyone. Thank you for the introduction, Laura. When we, looking at KSB, just a little bit of background on KSB, we're about 100 miles west of Chicago. So we're in a very rural setting, underserved health professional shortage area. And so telemedicine, while Chicago's down the street, and very well adopted, telemedicine in the rural setting was lagging. And so our challenge was around bringing that up to speed. And so we started with telepsych in the outpatient behavioral health space, as well as the inpatient behavioral health space. And we used providers in the suburb area. And then more recently, we've expanded telepsych to our ED. In August of 2019, we launched an asynchronous urgent care platform, and that was available 24/7, unscheduled visits. And the asynchronous platform there allowed individuals to receive care for more than 20 common conditions, where they could answer questions about their symptoms, and the survey would intuitively adapt to each response. So the follow-up question would ask them more specifics about their previous questions. The system had algorithms embedded in it that allowed the patient to be triaged out if something was determined to be inappropriate for telehealth. But if it was appropriate for telehealth, which we saw 60 to 80% of our cases coming through were appropriate for telehealth, a provider would get notified, and then they would review the case. And right now our average response time is anywhere between 10 to 15 minutes. And this platform really took off when we launched it, and we added a COVID screening to it in March of 2020, this year, which really got a lot of traction, allowing people to be categorized into various buckets and then triaged and sent to the appropriate next level of care. In response to COVID, we did launch a synchronous scheduled office visit platform. We realized that a lot of our patients were not, obviously outpatient volumes decreased, so we launched a synchronous platform allowing for real-time audio video with the care team for routine visits beyond just our urgent care protocols in the asynchronous platform. We did then move that synchronous platform to the inpatient setting, where we were able to do inpatient consults and specialty consults where appropriate. And then now we are actually adapting our asynchronous platform to do telebehavioral health. So now we're adding protocols for depression, anxiety, PTSD, ADHD, and substance use, whether that be alcohol or drugs, and using that same type of evidence-based tool to ask them questions based off their symptoms, available 24/7, and then getting connected to the next level of care. And so KSB, I like to think we are pretty ahead of the ball with our various modalities of telehealth in the rural setting, and they have gained a lot of traction, especially since COVID era.
Akil, that's very impressive work in a very large scope of patients that have been served by your programs. Desmond, can you share with us the settings and types of patients you've been able to provide via telemedicine services?
Yeah, of course. Thanks for asking the question. And, our organization, as Laura mentioned, we're an independent primary care provider. So we're not hospital, multi-specialty, which obviously brings some complexities to any virtual care, design and delivery system. At One Medical, our virtual care services really grew organically from the very early start of this organization. One Medical was founded in 2007, so we've been around for a little over a decade. At this point, we have about 100 offices nationwide, and we have a 50-state virtual only strategy as well. So we've had the benefit of virtual care kind of being a part of our DNA, if you will, from the very early going. So we've had an integrated care delivery system that presumed the use of both virtual and office-based care for pretty much every patient. So when we think about what patients have we used virtual care for, my answer is all of them. Our strategy as it relates to virtual care is that we want to optimize the patient's decision to access care and connect them to the right entry point, which oftentimes is not physically in the office. And certainly settings or reasons for use is quite broad. What I personally like about our approach to virtual care delivery is we have a fairly open entry point to virtual care. And I've noticed a lot of systems understandably constrain essentially the patient entry to virtual care, and they create these sort of specific lanes or channels that they should go down. And we've taken a little bit of a different approach, which is to really allow patients to elect to seek virtual care, and through a mix of both asynchronous modalities and synchronous modalities, help to right size their decision to access care and give them recommendations on where care should occur, whether it be in a virtual space, whether it be in an office space. On the virtual side, historically, we have staffed with a team of RNs, NPs, and PAs in the delivery of care remotely. And these providers are, for the most part, virtual only. As a result of COVID, incidentally, we actually launched our synchronous remote visits with office-based providers or PCPs. It was actually not something that we had done previously. So as far as strategy is concerned, COVID sort of dictated that decision for our office providers to also sort of dive into the world of virtual care. But we really look at virtual care as, for lack of a better way to put it, the interstitial fluid of our care cell. It seeps into all the nooks and crannies before the visit, after the visit, in lieu of an office visit, an extension of our office-based PCPs, or even in some cases, a replacement to them. And we really look for those opportunities to provide the right care in the right place at the right time, which I think is something that, it's sort of a phrase people use and it's repeated over and over again. But one of the joys of telemedicine for me personally, and I think one of the huge possibilities in our system, is to do exactly that. We are disconnecting patients and providers from historical barriers like time and geography. And this technology is not terribly complicated, nor is the delivery of care in this setting terribly complicated, as long as you're designing for it. And we're getting these things out of the way that have been, access to care barriers. Akil kind of pointed out, especially in the rural setting, just having the right provider there for the patient has historically required them to be physically in a certain place at a certain time for that patient. And we're using telemedicine to turn that narrative upside down.
Thank you, Desmond. That's very impressive and very progressive. Many organizations have struggled to kind of make that part of the DNA of a good complement of traditional in-person and virtual visits. I have had some direct experience with that. Prior to COVID, we had about 22 different telehealth programs deployed across 18 acute care hospitals and serving our ambulatory, post-acute, and home care population. And just like both of you had mentioned with COVID, really the transition to making it a nice to have, and now it's a need to have, and how are we moving things forward? we saw that directly. We had launched 100 new telehealth programs over the course of 3 months once COVID hit here in Illinois in March. And I think probably the thing that was most inspiring to me is that providers were completely embracing this functionality. And previously, there was some hesitation, much of that related to reimbursement and questions. Could I really properly care for patients? Could I provide the same quality of care to these patients virtually as I do in person? And so I think we can all agree we've learned a lot of things with COVID that we've been able to see the true benefits it's provided patients during this critical time. Desmond, how have you seen the patient's response to using, synchronous or asynchronous delivery of telemedicine services? Can you give us some feedback on that?
Yeah, patient engagement has historically been pretty high with respect to telemedicine. We do sort of like a post-video survey of patients as far as gathering some information around how they felt the visit went, their overall rating. And it's almost become, I don't want to say a useless metric, but it's so persistently positive. We have like a 98% patient positivity response to our video-based encounters. So it's a great data point and we're very happy to have it, but at the same time, it's universally very broadly accepted. Because we have been invested in both synchronous and asynchronous platforms for so long, we're really able to bring a patient into our universe and sort of introduce them to virtual care from day one. And so it's less of a shift for patients when a new service line comes on board after they've been with One Medical for a couple of years. They're already accustomed to receiving care in a virtual setting. The other thing that we do is we don't shy away from encouraging patients utilize virtual care. You mentioned reimbursement, Laura. We've been in a fortunate place with respect to how we've enabled virtual care in our setting that's less explicitly driven in the fee-for-service realm. And so we're able to make just much more creative decisions with our patients around virtual care is the right decision for you today, and here's why. And we can have a much more honest and engaging dialogue with patients who might have that idea that office is what they need. And I know a lot of healthcare systems are going to say, well, yeah, office is what you need because that's what we're going to get paid for. And obviously that's been shifting tremendously. So that investment can shift a little bit. But from the word go for us, we've always invested in the idea of we want to provide care to you in the right place. And that may be different than what your historical expectations are. I do find the asynchronous care channel to be a unique one because I do think patients kind of come in with a certain expectation. And if those expectations are not met, sometimes there can be some friction or some tension there. And any clinician who's practiced in telemedicine can acknowledge that diagnosing by, patient-based questionnaire, maybe a couple of back and forth chats can at times be challenging. And unless they are fairly straightforward cases, as you add in certain complexities, you really do need to escalate that patient possibly to a synchronous channel, possibly into the office. And sometimes there's a little bit of a mismatch as far as setting expectations appropriately. And where there maybe is frustration or attention, or the patient doesn't embrace the technology so directly, it's really that opportunity around setting expectations was missed. Or it wasn't done appropriately. So I know for us, that's often been a stumbling point where there was frustration around something, and we bring that back to evolve our platform to be more and more patient-centric, clear, consistent, but it's a work in progress. So our engagement's very high. Lots of patients use virtual care in the One Medical setting. Over half of our patients are regularly interacting with virtual care, but we certainly have room to grow.
Thank you. Akil, same question.
Yeah, well, Desmond said something that I wish I had, and it's, that their patients understood telehealth and it was ingrained in the culture. We brought it in here and we heard tele who, and so that was the biggest thing, was letting people know the service existed. And again, we were fortunate enough to have launched our asynchronous platform pre-COVID. So marketing was a huge thing. Once it was out there, that conventional saying, if you build it, they will come. Not always, right? You can have this wonderful feature out there. And so I did a lot of presentations, a lot of talks, a lot of meeting with Rotary groups, Lions clubs to let them know it was there. And when they started to use it, it was a slow ramp up. We did an internal pilot with just our KSB population only, or those on our health plan, to work out kinks with our provider group. And the feedback out the gate was very positive. Like our first encounter, patient completed the visit at 4:02 p.m. She knew what a UTI was. She's had many UTIs before. She couldn't get in to see the doctor for another day or two, and she just needed her Bactrim. All right, she needed her antibiotic. And so she completed the visit at 4:02. Provider reviewed it within 8 minutes, saw that it was a classic case of UTI, prescribed the prescription. When she got her note back, text message, she was able to read her care plan, hit fill prescription on her phone, which opened up a map of all the pharmacies in the area. She sent it to her local pharmacy. In a matter of 20 minutes, her prescription was already sent to the clinician's office, and she didn't talk to the pharmacy, and she didn't talk to a single human the whole time. And we've had other use cases of doctor's office, pediatrician's office doesn't open until 9 a.m. and it's 6:30 in the morning and child is headache or earache. What do I do? Do I go to the ED? Do I keep them home? Do I have to call off work? Boom, fill out the survey in the middle of the night even and get a response within 15 minutes about exactly what your right care is. As Desmond mentioned, right care, right place, right time. KSB, healthcare has always been traditionally provider driven, right? You come to my office when I say you can come on this day, you wait in my waiting room. I'll see you when it's convenient for me. And our CMO and our team really wanted to flip that narrative and make it more patient centric. And so when a patient is now able to right time whenever they need it, right place, wherever they're at, and through the asynchronous platform, getting the algorithm, seeing them, triaging them, getting the right care, that feedback has been really, really positive. But then Desmond nailed it with expectations, right? When we then added the COVID screening to our asynchronous platform, everyone thought that they were going to use the COVID screening and get referred for testing right away, right? Every sneeze, cough, sore throat thought that they were going to get COVID tested. And when we reviewed it and said, no, you don't have any risk exposure, you don't have any travel concerns, there's no shortness of breath or anything like that, this might just be a different viral URI, people got really upset and our ratings went down. We were at 96 approval, and now we have, with other customers using the same type of platform, have even dropped down to a little bit below 80. Just mainly around, I thought I was going to get tested and I didn't. This was a bunk. So it really then boiled down to setting expectations. And so with our care teams, they sat down once we launched the synchronous platform. It was really the provider had to sit down with the nurse and the MA and say, these are the patients I want to see. Then you had to call the patient and onboard them, explain to them the benefits of telehealth. Why do I want to see you via telehealth? Why is it going to be beneficial for you? And the minute you told people, hey, you don't have to travel, you don't have to wait in a waiting room, and you can avoid unnecessary exposure to COVID, sign me up. And so that was really about, explaining the benefit to the patient and then allowing them to decide, yep, I want to do it, or nope, I still want to be seen in person, and really putting the control in their hands and making it more patient centric. And that really helped us get positive feedback on the synchronous side of things as well.
During COVID, did you, what sort of shift did you see between your traditional primary care visits and changes to those volumes, and then ramp ups on the virtual side?
Yeah, I just to make sure I was factual, ran the numbers again today, and 100% of visits in Q1 of 2020 were in-person traditional. We had negligible amount of telehealth. I think some of them might have even been just registered wrong. And then we saw approximately, just in clinic visits, a little over a 25% decrease in visits going into Q2. But then we saw an increase of up to 15% in telehealth visits. So telehealth our onboarding team in a matter of 2 weeks onboarded 65 providers. Once we hashed out the workflow, we knew how it was going to work and integrate with it, got the iPads, got the technology, got it in the hands, trained them. It blew up overnight, and we saw a massive increase in telehealth visits. The number, this is going to sound like I made it up, but I promise you I didn't. 13,000% increase in visits from pre-COVID to post-COVID, just because we brought in a new technology and it, caught like a wildfire.
That's remarkable. And Desmond, how about you? Since you've been in this space for quite a few years and have had a platform, what sort of shift did you see from your traditional visits that during the height of COVID, how that shifted?
Yeah, It's interesting that even though the numbers may be different, that if you look at the broader national trends about where visits were occurring and when, so March, April, early May, virtual care was through the roof. Same would be true for One Medical. Both, and again, both our traditional video visit or video chat platform that was with our dedicated virtual teams, and then with our scheduled remote visits with our office providers coming online, the utilization was incredibly high and our in-person care was dramatically reduced, consistent with what you were seeing nationally. Over the summer months, also, virtual care seemed to lull a little bit and our in-person visits began to come back on board. At this point in time, we're pretty much back in line with our in-person office visit sort of expected volume, with the added benefit of sustained increase in our scheduled remote visits with our PCPs, and our virtual care volume also, the dedicated virtual care volume also at a higher than average rate for this time of the year. The other thing that I wanted to mention briefly as far as the patient acceptance that Akil had brought up is that providers get to dictate who gets to use it and when, using office as the entry point. So one way that we can think about shifting our patients to virtual care utilization, if it's appropriate for them, and it should be appropriate for everybody for at least something, is, hey, I want to see you back in 2 months and we're going to do it by a scheduled remote visit. And here's what that's going to look like. So you can tee the patient up for the expectation of using virtual care for that next touch point and get ahead of that sort of adoption curve by getting them prepared for it before it even is planned to occur.
That's a great way to engage and drive your adoption with your patient population. You know, one question that seems to always come up is how are we ensuring that there aren't disparities? You know, patients that don't have technology or patients that are having trouble using technology. How are each one of you addressing that? Now I'll give that to Desmond first.
It's a good question, and I don't think it's one that we have inherently resolved. I mean, I think first and foremost is establishing a degree of parity in access to virtual care based on platform, so that the patient has the ability to access virtual care through our mobile app and is able to do so equivalently through their desktop computer, their tablet device, what have you. The data out there as far as access to high-speed internet, obviously we have these pockets where high-speed internet is not as readily accessible, and this can be very problematic for certain patient populations. But the platform itself, establishing parity across kind of all of those entry points, there's not some major bias towards use of the mobile application as opposed to web-based, because that's just not going to be appropriate for some patients. They don't have a smartphone. The number of times I've spoken to patients who say, I don't do apps, and just it's not part of their repertoire, and it's not really for us to force that on them. The other side of it is from a equity perspective is, if you've built a virtual care system that is difficult for patients to use, or have bought into one that's difficult for patients to use, you've made a very poor decision in investing in your virtual care platforms. By design, virtual care should be simple and accessible. Other things that we've done is advanced texting patients before visits to help ensure that they've got the right technology, that they're prepared for it, that they don't have any questions. We've also had, any times we've had longer hold times by traditional phone-based triage, which many healthcare systems are very accustomed to, using text-based to say, hey, would you like to try a video chat today? And actually, again, proactively route patients into our virtual care system. Most of our patient populations are in larger sort of metropolitan or suburban areas. So I think Akil might have some really interesting insights as far as that kind of rural digital divide, which is a really important question to be answering. And then obviously we also have our more aging or elderly patient populations we need to be mindful of. It's interesting though, less specific to One Medical, but generally there was a report commissioned to Congress by MedPAC in 2018, where they investigated virtual care utilization. This was prior to COVID. And the fastest growing segment for virtual care utilization for Medicare beneficiaries were adults 80 and over. So while they were a small slice of that utilization, they were among the fastest growing. So we shouldn't presume that it's difficult to access, but we do need to course correct for whenever we're finding that, yes, it is a challenge for our patients, and work closely with patients to understand what their challenges are, not presume them, and work collaboratively to solve them. So we do a lot of design thinking at One Medical in order to really identify the patient experience and the patient journey and make sure that we're really optimizing that as well as the clinician experience.
So Akil, I'll let you give your feedback.
Yeah, so that the initial question about ensuring equity for access, that in rural America is the biggest problem, right? And that's become further apparent through a lot of education and schools going remote, right? Well, I don't have internet at home. Our local high school did one thing with the one-to-one program giving Chromebooks, but you can give a Chromebook and not have internet in what's that going to do? And so what we had to do is, there's no answer to it right now. I don't think there's a solution to it right now, but we had to work with social service agencies. There's a lot of, in Illinois, there's a lot of agencies that are willing to help people connect to the internet, give them, Comcast was willing to give reduced rates for the schools. And so we kind of were able to tap into that. There's other social service agencies that give, smartphones with limited mobile data, but large in part, if you did not have the ability to connect to the internet, that did preclude you initially from using telehealth. And then we would work with them and trying to, social service agencies to get them access. And then, Desmond named the next point over there was it, even if they've got access to it, if it's difficult to access the internet, but if it's difficult to use it, you've lost the battle right there. And so it being patient-centric is very, very important. And so when we evaluated different platforms, one thing that won out ahead of us was, we really enjoyed the web-based platforms, right? So you could avoid downloading an app. That's just an extra step, having to download that app, and then especially for our older population, that also is a barrier over there. So we looked at a web-based platform. In the platform, you're able to actually text message a link to the patient. So just type in their number, hit send. On their end, they get, hey, Dr. X wants to do a virtual visit with you. Please click the link. Click the link, type in your name, and you're in the waiting room. And as easy as that sounds, we still had problems with people connecting, right? They didn't get the link. Now I'm learning recently that cell phone providers are blocking that text message as spam. So then we've upgraded the platform, and now they can go to a website, and in the website, hit the drop-down menu and join the patient's waiting, the provider's waiting room that way. But as few steps as humanly possible is going to be important, because our population using telehealth is not the young, healthy TikTok, boomerang, whatever patient, whatever they're using these days. It's our older patients. And I've even gone as far as going out to a patient's house, standing in the doorway with them and helping them connect, because they've got anxiety. We need to look at their, their behavioral health medication, and they have to be seen right then and there. And so not that every health system is going to do that. These were very limited use cases, but if they can connect, it defeats the purpose. And so the fewest steps, the better. And web-based over application is my preference, not to say that one's wrong, but just, again, it comes down to the fewer steps.
Yeah, I've actually experienced the same thing at Amita. We do have a very streamlined approach to how easy it is for a patient to connect, but you always run into a patient that maybe has difficulty. One of the strategies we implemented was we created a video that was like 30 seconds long, especially for any patients that we thought would have some challenges, especially when we were scheduling our virtual provider office visits. And so that really seemed to help streamline the process. They knew what to expect, and we saw some success with that. But I also think that we've even thought internally about the disparities. Amita's throughout this, we're a very urban system, community hospitals, but many hospitals in the city of Chicago, where we have some significant challenges. You would think in Chicago you'd have great internet access, and there's a lot of challenges in the city of Chicago. And so we've been trying to brainstorm, how can we make this more accessible to patients that don't have devices? Really trying to partner with community spaces like libraries and setting up a secure location for those patients in a set community so that they do have the ability to have that access. But I think that's something we're all going to be faced with as virtual care is kind of main stage and now being fully embraced, where we're going to have to come up with creative solutions to ensure that patients who don't have devices or don't have internet access can go to a location within their community so they can still be seen for initial care and follow-up care.
You know, just as a follow-up to that, we sometimes had to wait for, you know, if grandma or grandpa's home, they don't have a device, we're on the phone with them. Okay, well, my grandkids are coming next week. All right, we'll do the visit with you next week. And so, yeah, sometimes you have to wait for the technology to come to some individuals.
And to add to that too, I mean, that's again, one of the really nice benefits of telemedicine, and depending on the platform that you're invested in, there might be a kid or whomever that's 3 states over that can support their, you know, loved one, family member, et cetera, getting onboarded with the technology remotely, and that could even support in a shared visit setting if your technology supports it as well. On the non-digital divide side of the question, just from a kind of utilization perspective, I'm kind of curious for Laura and Akil, to what extent are folks within your system even aware of or familiar with the available telemedicine services and routinely communicating them to patients with the various touch points they have through your system?
Laura, you want to go?
Sure. So prior to COVID, on the ambulatory side of care, we really were only using virtual care within behavioral health and had a pretty robust program since 2013 for scheduled visits virtually. Once COVID hit, we onboarded 750 employed medical group providers in 5 days and had them up and running on a telehealth platform, engaged all of the office teams so that they were very well versed in it. But I would say since on the ambulatory side, it was very new for my organization. I think that in the beginning, we had some challenges with fully offering it and communicating it. I think there were a lot of questions by not only the providers, the office staff, the patients, but what we saw was a direct turn. So 0 cases before COVID hit. First month COVID hit, there were 50,000 virtual visits by the primary care providers. And so I think in that, that tells me that our providers completely embraced it, verbalized it, offered it to their patients, or we would have never seen 50,000 visits. But I will say that we had been on a journey to implement a direct-to-consumer on-demand strategy. And we were right in the beginning phases of it as far as the project launch internally when COVID hit. And then when COVID hit, we had to kind of divert and put that on pause. Since that time, we have launched a direct-to-consumer platform. And I would say I almost felt as though that platform was a little bit more difficult to get providers to really want to be involved in that program because it was a whole new patient acquisition point. It was patients that they didn't have a relationship with. And I also saw through that, you know, it was a great entry point for new patient acquisitions, or as Akil was mentioning, you know, at midnight, you're not feeling well, nobody's open, where can I go for, you know, to see somebody? The service is offered 24/7. Have seen a great benefit of that, but I definitely think we could do a better job marketing it to our communities, gaining better buy-in from our providers for that on-demand access to a primary care provider. it's still a work in progress. So Akil?
Yeah, along the same lines, when we launched our asynchronous intuitive questionnaire platform in August of 2019, I mean, we did full social media blitz, newspaper ads. I went on the radio, did a whole bunch of stuff, and we didn't really have much data on uptake, so we didn't know if we were succeeding or if we were failing because there was no rural health system kind of in that area, so there was no previous data. But as we wanted to continue to amplify, where we saw a lot of success was actually flipping the script. And instead of trying to have us do all these social media ads, we actually went to the triage nurses, right? They're getting a lot of phone calls all day, every day about conditions. And if they tell the patient, yep, we'll take care of you, but next time you've got this X, Y, or Z condition, use that, right? And then in the ED, when we discharge them for the ED, simple, trivial cases that they come through, we had the providers educated. And when the providers were telling the patient to use telehealth, and this is the use case and this is why to use it, that stuck a lot more than that Instagram or Facebook ad saying KSB Care Anywhere, use it. And so that was how we kind of started to build the trust. And then obviously when COVID hit, they couldn't get enough of it because it was giving them, so many people needed answers. They had so much anxiety, and being able to access that when phones weren't answered or things were ringing off the hook, that really then provided a lot of peace of mind to patients. And so I would really recommend utilizing your care teams to be your biggest marketer and your biggest advertiser versus some of the traditional ways we think of doing social media posts and things like that.
That's great. I'm going to ask Desmond a question. What are the financial circumstances surrounding your telemedicine program?
Can you expand on that a little bit?
So as far as, trying to give those that are on the call, how costly is it to implement the telemedicine program? What have you seen directly with what you've done within your organization? Because there are many times provider offices or health systems or clinics think that this is a very costly endeavor. So can you share your experience?
Yeah, absolutely. I'm a little worried my internet might be. Can you hear me okay?
We can hear you.
Sorry about that. Virtual care is expensive for sure. And depending on how you've established your system, that is going to be more or less true. And by far, we spend the most money on staffing. So our clinicians are our major cost driver in this setting. And also how you decide to deliver care is going to dictate your expenses. So while synchronous real-time audio video connection is going to be the most reliably reimbursable thing in the telemedicine space at this point in time, asynchronous care is a lot less expensive. And having a clinician who can reasonably manage 5 asynchronous cases simultaneously, they can only do one video. And depending on how you set your system up, it may not have sort of the schedule constraints that a traditional office setting would. So these are things that have to be balanced. And for us, we're always looking for opportunities not to just provide care less expensively, but to really make sure that if a video was required, that it was required, and that if we have opportunity to shift over to asynchronous, that we can do so. From a cost perspective, a lot of our strategy relies on enterprise contracts. So as far as actual revenue is concerned, it's often coming through those contracts and less through traditional fee-for-service, as I mentioned previously. There's a lot of employers that are investing in this stuff right now, so they see this as a real benefit that they can offer to their employees. So that's part of the way that we generate our revenue related to the, call it non-traditional services offered by our system. Still, staffing is a major cost driver for us more than anything. Obviously, bringing remote visits online and billing in a more traditional fee-for-service setting has sort of level set some of those costs, but it's an ongoing conversation and it does dictate some of our investment and decision-making. Another one of the benefits, but also challenges that we face in our environment is all of our technology is homegrown. Our EMR is proprietary, our virtual care system is proprietary. So there's a cost associated with the engineering and the product support for that we are not kind of offloading to a third party to just plug their system in. So those are decisions that were made years ago, and we continue to reevaluate them on an ongoing basis. But one of the benefits to that piece in particular is it's allowed the virtual care delivery system to be innately integrated. It doesn't feel different to provide virtual care as it does to provide office care. The system is designed to essentially be the same clinical experience. That's been a huge benefit for us in actually getting clinicians really adopting it and using it and being happy with it. We have a lot of work to do as far as the actual costs of virtual care, as I mentioned, but that's just a little bit of background on it.
Oh, that's great insight. And Akil, what have you seen?
Yeah, I'm very happy that Desmond and I are here, because I think we got different sides of the spectrum, right? Because from our standpoint, telehealth, our providers are part of our medical group. That's a fixed cost. Our staff is a fixed cost. These are guys who we've already paying for and on payroll. So during COVID, then it was, with not money coming in from in-person visits. That was the real what am I trying to say over here that was a real concern. And so for us, telehealth was not as expensive from the synchronous side of things to implement, right? When we were looking at different platforms, you had opportunities to do a per visit, basis. You had opportunities to do a per member per month, like a per user per month. And we really went for the per user per month. It was a fixed cost that we could control, and we would not be penalized for being successful with telehealth. And so that would be the first thing I'd recommend for folks who are looking out there to do it. And then we did not have the advantage of being such a robust telehealth company like One Medical. And so our asynchronous was actually more expensive than our synchronous platform, because we did have to purchase that from a third party and then, KSB-ify it, so to speak. And so we don't have any dedicated telehealth providers here at the system. They kind of all have shared responsibilities. It's a hybrid model. There may be a day now where your morning's got to do some in-person, some telehealth, and that's how the day really operates. When we did launch the asynchronous platform pre-COVID in August of 2019, we really did like a shared staffing model. We got a number of motivated providers on board, and we just developed a call schedule between them. And some of them prefer to do it during their clinic hours, because while they're seeing patients, the light switch is on, and so they're rocking and rolling. And some prefer to do it on their off days, and the ones on the weekends, they alternated. And so that really, because of it being rural and because of us not knowing if it's going to be successful, how much money is it going to make, is ROI positive, negative, our providers agreed to do it, as part of their normal duties, and staff telehealth that way. And then the synchronous side of things, we just found a platform that was really easy, fixed cost, controllable, and that just brought in visits that we were allowed to seek reimbursement for. And if it wasn't for those temporary parity laws that were, as part of COVID executive orders, a lot of things would have been a lot more difficult and bleak for our health system, because there was a mandate for private insurers, and obviously CMS was on board to reimburse telehealth as one-to-one with an in-person visit. The only thing we really missed out on was the facility fee, but that really did provide a life raft for our organization, particularly during April and May when visits were down big time. And so that was really our kind of take on the financial side of things.
So I probably have a little bit different of a take. Each one of us are kind of in some unique spaces. We started with a scalable telehealth platform that back in 2013 that really can be loaded on any existing laptop, desktop, iOS, Android, telemedicine card, virtually anything. Our original investment was actually funded by some very generous donors. These donors donated $320,000 in order to support a telestroke program in 10 acute care hospitals. And at that time, we went back and said, okay, we really need to design a telehealth strategy for the organization. And how can we use these dollars most effectively? And so what we were really able to achieve is purchasing a scalable telehealth platform that could support any clinical initiative. But then we supported telestroke with the Lamborghini of all telemedicine carts in every single emergency department with peripheral devices. So, stethoscope, otoscope, dermoscope, so that not only were we supporting the telestroke program, we were going to support any sort of subspecialty services throughout, the years now, which now I look back on it and said that was probably the best decision we could have ever made. And why I say that is that, we had a fair amount of specialty acute care telehealth programs deployed across our 18 hospitals, telepsychiatry in our emergency department and general medical floors, inpatient telepsychiatry rounds for our behavioral health population that was admitted. We've had specialty programs like telepediatric hospitalists. Anytime a pediatric patient would come into our emergency department, we were still tapping into that same telemedicine cart. So part of our strategy was to reduce our technology footprint. And we tried to push the needle with the technology so that we'd have one telemedicine cart in the emergency department. Any provider could utilize it, but then how could we integrate language interpreter services? So we were able to do that a couple years ago so that we didn't have any barriers to patients that were coming in and we didn't have an on-site interpreter. And we wanted to create this very efficient process where a provider who was consulting on a patient in the emergency department with a click of a button could just bring in a video interpreter, 53 different languages, and it would be a split screen so that the patient and family member could actually see the provider and the interpreter instead of having a phone talking to a telemedicine cart or an iPad talking to a telemedicine cart. And then from like a staffing perspective, we've used a variety of different models. So we have absolutely tapped into our employed provider group, specialists, primary care physicians, and then there have been some specialties where we don't have enough providers. We know that there's shortages of psychiatrists, intensivists. We've even seen that we've needed help with neurologists. And so we've been lucky enough to find partners, vendors in the industry that would collaborate with us, and we would contract with them for the providers, but they would use our scalable platform. So we didn't have any increased costs related to the technology. I have a dedicated telehealth clinical and IT team. So we're able to customize each one of the clinical workflows so that we're aligning it with what happens in traditional care. But from a financial perspective, I'll give just one very specific example. 10 acute care hospitals in a traditional model of having 24/7 access for neurologists to support a stroke program would have cost my health system $3.5 million a year. And instead, through our telestroke program, my health system pays $560,000, which basically equates to $60,000 per acute care site. So from that perspective, we've seen a direct cost savings to the organization. So let's shift the conversation over to credentialing and privileging guidelines that each one of you have seen, and how have you addressed that, both from Akil, I'll say from your local perspective at your facilities.
So I think what's made it really easy for us is a lot of telehealth systems, when we were evaluating it, used outside providers, right? You had providers in New York, credentialed and licensed in Illinois to see your patients. Where we wanted to differentiate ourselves, especially since it's a rural program and we're trying to, really maintain that homegrown, home touch field, is we used all of our own internal providers. Every provider staffing telehealth at KSB, whether it's the asynchronous platform or the synchronous platform outside of telepsych, are all KSB providers. And so they're already licensed and credentialed with the facility. From an insurance standpoint, they're already covered underneath our malpractice. So that really made it a lot easier for us for that part of the equation. Now, when COVID did come and hit, there were some other providers in the area who offered assistance, that, hey, should doomsday come, what do we got to do? And we were able to get those folks licensed and credentialed pretty quickly in the event that we should need them for staffing and get them admitting privileges. But thankfully, so far, we haven't had to use them. But that's just kind of our experience of it, being that we used only KSB providers. It was just who wants to be part of it, and let's do it.
And did you do emergency credentialing and privileging to get those providers on board during COVID? Or did you not need to do that?
I don't know the answer to that. I don't think so. I just basically, when we know we needed help, I got the names from the urgent care facilitated, sent it to my credentialing department, and they took care of it. So I don't know exactly if it was emergency or not. I'm sorry.
Desmond, do you want to give us your insight?
Could speak more to the licensing side of things than anything, but we have a very similar reality with respect to all of our providers are employed by One Medical. We don't have independent contractors with respect to virtual care delivery. What's been a unique challenge for us is being very familiar with the licensing process in the states where we already had physical offices and being very comfortable with it, incredibly competent licensing and credentialing team who had a well-oiled process, and then suddenly getting thrown into a 50-state virtual solution. You know, I don't need to tell anybody here, we have a patchwork of laws from state to state that treats a PA or nurse practitioner, happy NP week, by the way, or an RN differently, depending on the geography of the patient. And that's been a really unique challenge for us. One, just the timelines for licensing, getting an individual provider, 10 state licenses, an example. And we're working with third-party vendors to accomplish this ultimately, because we just don't have the bandwidth to do it internally. So there's a cost associated with that. The other thing that I think is a unique challenge is the laws around virtual care delivery are also different state to state. And if your system does not account for that, you must rely on clinicians to retain all of this knowledge about, okay, I'm providing care to a patient in California right now. Now I'm providing care to a patient in Nevada. And if your system is not sort of interoperable with respect to legislation and just the reality of providing care in a given state, that is left to clinicians in order to execute on consistently and effectively. And that's another unique challenge I think we face, as well as other systems that are very suddenly getting into more of like a multi-state approach. So the licensing side of things has been a real challenge, and a lot of states are very backlogged on licensing timelines for this reason. And it's just something that we're kind of handling on a day-to-day, week-to-week basis, just getting another clinician through that licensing process and online to provide services reliably. That means, of course, in those places where we're providing care in a given state, we're doing so in a scaled way, only based on what our staffing can support. But that's been a very unique challenge of 2020. The timelines, the multi-state licensing rules, the legislation, and we need to have a real conversation as a healthcare system nationally if this is appropriate. Why do we do this to clinicians? Why do we do this to healthcare systems? In what way does it serve patients, patient care, safety, et cetera? So I think that's one of the kind of nice byproducts of all of this is it's really bringing that particular issue to the forefront. There's some federal legislation that's already coming to bear that wants to address this, probably not in a definitive way, but to really have an earnest conversation about, what might federal licensure look like? We have a physician compact, we have a nurse compact, there's an NP compact. It's just not live in enough states yet to be in effect. There's no PA compact yet, but they're talking about it. There's all these professions are in this incredibly different state of reality related to something that by now, frankly, is commonplace. So we've got a lot of catch up to do as far as licensing is concerned, as far as legislation is concerned. And I would say organizations like ours at One Medical, it's painful dealing with those cross-state realities for sure.
Yeah, I've had that same experience. I provide services to some non-affiliated acute care hospitals, which requires me to get nurses and physicians licensed in states. For Illinois specifically, we have some significant challenges because from a nursing perspective, we're not part of the nursing compact. And so it makes it extremely difficult to get nursing licensure in the compact states. It's a very lengthy process. I will say the physician licensure process is amazing because of Illinois being part of that. which has really enabled me to strategically plan for having my physicians licensed in a multitude of states. Right now, it's a $750 one-time fee for the initial licensure in one of the compact states for a physician. And then you have 365 days in order to apply to any one of the other states that are within the compact, and you only pay $100. So from a financial perspective, I had to really think about you know, how I was planning and what states we were going to target that would make sense for them to get their licensure in. But it definitely is an opportunity nationally in order to standardize that licensure process. And instead of all of these caveats we have in different states, it really is a barrier to providing services. And it also slows down the ability to bring in scarce resources to different areas because of the backlog of how long it takes to get a license. So it takes some very forward-thinking planning in order to accommodate for the delays in the licensing process. From a credentialing process, I've sing internally, we've had a pretty streamlined approach where we didn't create separate telehealth privileging or credentialing at our sites. We just added it to the in-person care delivery. So if you were a bedside intensivist, we added our tele-ICU intensivist into that. Or if you were a bedside psychiatrist, it would just fall into that credentialing and privileging. And we basically just added it as part of that term of what they were available to do within that credentialing and privileging. I'd just like to remind the audience, if you have any questions, please feel free to type them in the chat feature. We'd be happy to answer any questions as we're going through. So I'd like to kind of turn our discussion in another direction. You know, from what we've seen of what each one of you have right now, what are you envisioning, or how do you envision the future and how the healthcare delivery system will change? And what other tools and technology are you looking at as we move into the future?
You know, this is Akhil. You know, as we look to, you know, shift to where it's going to be more financial implications on the provider team, I really do see telehealth becoming more of a mainstay. I read something pretty interesting that says that telehealth's got to go from the Blockbuster model to the Netflix model, right? From it being aggregated all central and, you know, and the subspecialties to now being available in all homes. And so what we're looking on the next frontier for our health system is pairing telehealth with remote patient monitoring. All right. So as providers are held more financially responsible for certain population groups and their subset and their panels, we're looking to leverage the ability to, you know, real-time check-in to where just, you know, text message check-in and use those peripheral devices that collect those biometrics and being able to monitor our particularly higher risk patients and reduce those readmissions and improve health outcomes. And so for us, the next frontier is definitely going to be remote patient monitoring with, you know, and blending in telehealth in with it.
Desmond?
Kind of a similar answer, to the extent that RPM and mHealth applications in telehealth have real opportunities for healthcare systems to work more intelligently with their patients and proactively. Like, at the end of the day, patient elects to use virtual care. That is a patient-driven decision that they elected to receive care that day in the vast majority of cases, even if we said, hey, follow up in 3 months. And what RPM allows for and various mHealth applications will allow for is intelligent nudges or sort of monitoring of patients that create intelligent alerts for clinical teams. And you can look at large swaths of data very quickly and very easily and be much more strategic about your intervention. So those are definitely areas that we want to be investing in. Additionally, there's a ton of data readily available through if I had my Apple Watch on, things that our patients are already using every single day. And while a lot of standards may not already exist around what we can learn from that data, we can elect to bring it into our systems and start to be the ones to say what we should do with it. So, a huge percentage of your patients are probably wearing an Apple Watch, some kind of smartwatch, Fitbit device, or have some other thing in their life that tracks data for them. That is an opportunity for your system with that integrated data to learn about your patients and better support them in collaboration. So that's definitely an area that we want to invest. And then additionally, and we're seeing this nationally, the real shift into asynchronous care. I mean, Akhil's, you guys were invested in asynchronous care initially, which I think is fantastic. A lot of these other systems are learning that the patient doesn't actually want to talk to you, by the way. They're like, we're surprised when we're like, why wouldn't they want to spend time with me? Actually, no, I just want to get this thing and move on with my day. So really making for the asynchronous side of care to be as robust, as intelligent, and as patient-friendly as possible to really enable care on that side. The other thing I would say here, and this is something we're doing at One Medical, and I would encourage healthcare systems are thinking about as well, we need to simply just start defining the type of care that happens in person, down to the condition. Like your average uncomplicated sinus infection does not belong in the office, pretty much ever. And to what extent are you evaluating where care is occurring and finding opportunities to shift that into the virtual space, because that's just where it belongs. So there's a big part of this that, rather than sort of presuming the direction that we want to go, it's a lot about identifying what are the challenges that we face within our healthcare delivery system, either for clinicians, for patients, or both, and how can we use telehealth to solve them. There's a well-known physician, Judd Hollander, out of Thomas Jefferson University in Philadelphia, and his motto is telehealth solves problems. So it is not simply this shiny new thing we can offer our patients, or the only way patients can possibly get care when there's a global pandemic. It is about identifying waste in your system. It's about identifying needs for your patients or your clinicians and figuring out if telehealth is a potential solution for those. So those are opportunities we're always looking for. And it doesn't necessarily presume where we'll make the investment. It's about identifying what those challenges are and then beginning to design solutions for them where they exist.
Just to tag on to some of the points Desmond mentioned, as we kind of look to the future in a rural healthcare setting, the best way to make money is to save money, right? And so lowering costs is definitely at the forefront of our administrative team. And so staffing ratios is something to be looking at, right? And as you shift more and more out to telehealth, I really do see remote patient monitoring becoming a very valuable tool, because now you can look at a smaller care team being able to support a larger patient population, because you can have these technologies with pre-built algorithms and thresholds that allow you to, it automatically would triage your patients. So you log onto your portal, look at your dashboard, and you're seeing at the top of the list your 15, 20 patients who need intervention immediately. And these care teams, which may get smaller, will then be able to target their resources appropriately and not spend time on that healthy patient following up, because he's already managing his care through his app, AM Health, you named it. And so that is, I see, definitely being a big part of being able to control costs and maintain hospital profitability. KSB is unique in the sense of we're not actually part of any health system. We are one of the few non-for-profit, independently run hospitals in Illinois, and kind of the last of a dying breed. And so this is really going to be the next frontier for us. I also run corporate health at our hospital. And when you look at employer-sponsored health plans, this is also another big frontier that these guys want to desperately reduce their healthcare costs. So what is one of the most effective ways to do it? Well, right now, what we're doing is putting on-site clinicians and clinics on site to manage the patient population. But the next thing is now telehealth, putting these guys into plans where their patients can use it for little to no cost. Right now, our asynchronous platform is cash-based. When we launched it, the reimbursement codes weren't very clear, and there was a lot of ambiguity around it. So we just did it direct to pay. You put in your credit card, and if you get diagnosed, you get charged. And if you get referred for additional evaluation, there's no charge. And so I'm really starting to push that with some of our corporate partners, again, is leveraging telehealth with their patient population to reduce their health costs. So those are two, little tag-ons to what Desmond had mentioned there.
Yeah, I'll tag on to what Desmond was talking about too. I have seen the direct value of having platforms that you use in order to monitor a population of patients, that gives you color-coded alerts in order to identify which patients need to be addressed first. Have some experiences with, we have a robust tele-ICU program where we have a team of centralized board-certified intensivists and CCRN certified nurses that are monitoring the ICU population 24/7. Through that program, have been able to reduce ICU length of stay, hospital mortality rates, septic shock mortality rates, reduce duration of mechanical ventilation, proactively intervene on that patient population. And then about 2 years ago, my health system started using a platform that used 23 different variables, basically an acuity scoring system for general medical floor patients. So as soon as a patient was assigned a bed and had the first set of vital signs or labs that would come in, we developed a centralized model where we had a team of nurses that were monitoring that platform. And anytime there was a subtle change in the patient's condition, we would then use telehealth to actually go into the patient's room via an iPad that's on a pole, evaluate the patient with the bedside nurse, and through that program have been able to reduce adverse outcomes, rapid responses. One story really comes to mind in that program is a patient was in one of our emergency departments, was assigned a bed, was going to go to a general medical floor bed. Our team of nurses identified that this patient was actually in septic shock, immediately called the emergency department and said, you know, I'm seeing this patient's in septic shock. I really think the patient should be directly admitted to the ICU. That was changed. The patient went to the ICU, and about 30 minutes after the patient got to the ICU, coded. It would have been a rapid response on the floor, which could have potentially had an adverse event, however, was in the right care setting for the right team to be able to quickly stabilize that patient. We're also seeing that through our remote patient monitoring platform. So deploying tablets into patients' home with Bluetooth enabled devices with, you know, a scale, blood pressure cuff, O2 stat, glucometer. And then we do have that centralized team where they have a dashboard that's color coded, and then it really directs their attention of what patients do they need to proactively intervene on, you know, such as your CHF patient, where her weight is trending up for the last 2 days. You proactively do a video visit to say, Mrs. Jones, you know, did you take your Lasix? Mrs. Jones, what did you have to eat last night? To try to redirect and reinforce, you know, their nutrition plan, their medication, in order to avoid those 30, 60, 90-day readmissions. You know, frequently, I've thought about recently with COVID, we see how valuable all of these solutions are and how they're truly becoming part of care delivery. And it's really, I frequently say it's part of our care delivery, and our providers and clinicians pull out the tool that they need in order to care for that patient most appropriately. And they've got a whole suite of tools they can pull out. But I frequently think about, you know, how are we going to use AI in the future? How are we going to be able to take that virtual visit, that patient that's in their home, a prescription is ordered, how are we going to get that prescription delivered to that patient? How are we going to streamline that process of patients getting their labs done or their chest x-ray done, and really making that an experience across the entire continuum of healthcare, from your wellness, preventative, you know, managing chronic conditions, and then in the end stages of life, how do we best care for those patients? We have about 15 minutes left. I'm going to ask the participants if there's any questions. Feel free to either put a comment in, or you can take yourself off mute and ask your question. While we're waiting to see if there's any questions, Akil, anything else you'd like to highlight about successes, challenges that you've seen within your program?
Yeah, I think the one that might be pertinent to the group over here is just provider adoption too, right? I mean, you guys have talked about major successes with provider adoption, and we overall had that, but there was a lot of perceived barriers to, no, I'm not doing telehealth. No, it's not the right quality of care. No, it's not going to be effective. I need to do a physical exam every time I see the patient. And through research, through study, through just peer-to-peer talking, we realized, hey, no, you actually, it will be effective. And Desmond mentioned it, right? We have to set rules and protocols around what are the right types of visit for telehealth. A lot of visits can go to telehealth that, we can take out of the office and save office visits for more higher acuity care. And so we really just had to work through the barriers for providers. And at the end of the day, almost every provider on a medical group, besides maybe general surgery, are on telehealth. And so I just would make sure that you get buy-in from your providers, because if they don't like it or they don't want to use it or don't see value in it, doesn't matter if the patients want it. So that'd be my big one.
Yeah, that's definitely a challenge, I think, for all of us, is the provider buying and adoption. I do have kind of a success story to share about that. I've been at my health system since 2005, have had different groups of providers over the years that, would say, no, I'm not gonna do telehealth visits, or having one of my service line leaders say, I'd like you to talk to this group of providers. What I've seen over the course of many years is that if you openly listen to the concerns and you're able to address their concerns, give them evidence-based research, validate how this has been successful, there is an increased buy-in and acceptance and adoption. But I will tell you, the one thing that really stands out to me within COVID, I have one of our largest flagship hospitals that our medical exec committee contacted me and said, Laura, we'd like to onboard 100% of our credentialed providers at our facility. And we want to make sure that in every patient's room and on every clinical floor, there is access for them to do a virtual round, if they need to do a virtual round, or they want to engage a family member. 250 providers onboarded, and just thrilled that our flagship hospital has almost every room equipped with technology, so that we've removed that barrier and our providers can really see their patients and also engage the families. So I'm going to turn it, Desmond, I'm going to give you the same question. What successes, challenges, any last thoughts you'd like to share with us?
Well, first of all, Laura, I deeply appreciate the kind of scenarios you've sketched out to identify not how telehealth was better than nothing, but was actually better than the care that would have happened otherwise. And so it's less about maybe successes specifically at One Medical or in my experience, but that our healthcare system at an individual level and nationally needs to embrace telemedicine as a solution to the challenges that we're facing, which are very, very big. We have a growing provider shortage. We know we are several 100,000 physicians short of what the demand will likely be by 2030 or whatever measure you choose. The only solution is not to just train more physicians, which we should do, or train more PAs or nurse practitioners, which we should do. It's to optimize those individuals within their scope of practice and training, and to give them the tools to enable them to expand the impact of their care. In the rural health setting, you have a lot of these small hospitals that can't afford to keep X, Y, or Z on staff full-time, 40 hours a week, what have you. And telemedicine allows for a shifting of who is providing that care, whether in person or remote, and really maximizing somebody who wouldn't be a full FTE in a given hospital system otherwise, because you're borrowing them out through telemedicine to a neighboring system. So there's a lot of ways that we can use telemedicine to sort of optimize our approach to care. And I wanted to reference one thing that I'd love folks to think about, which is the healthcare quadruple aim, which everybody should probably be familiar with this. We're nowhere near to achieving it, but there are surveys or studies that have looked at where the waste is. And of those studies, there was one that said we are wasting about $1 trillion in our healthcare spending. and that about 50% of that identified waste, $500 billion or $500 billion, was related to failure of care delivery, failure of care coordination, and administrative complexity. So that should hopefully resonate with you all, but to think about telehealth ultimately as a solution, not to everything, but there's a major entry point for telemedicine in some of these huge areas of current healthcare system waste. So I think that's so cool that we get to sort of free ourselves from a lot of these historical barriers and boundaries, and now even more so with all the stars aligning, legislators, insurers, payers, healthcare systems, all kind of starting to row in the same direction on telehealth, that it's really going to enable this to become a part of our care delivery for here and forevermore. And so that's just very, very exciting for me. And I hope that you all are as excited as I am.
Well, Akil and Desmond, thank you so much. The insight has been extremely valuable. You are both very versed in this space and are both doing some amazing things. I haven't seen any questions, so at this point, I'm going to turn it back over to Jennifer.
Great, thank you. Can you hear me?
Yes.
Good. Sorry, I had a bit of a technical difficulty myself as we were talking about technology. So glad that you all can still hear me. So yeah, I am happy to thank all of you for joining us today for our session. Thank you to the moderators and the panelists for all of your participation. We ask that you please complete the course evaluation by going to your My ACHE page and selecting My Online Learning from the helpful links section on the right side of the screen. And from there, you can then click on the Access My Courses link and be able to get back to the evaluation. And if you're already in the learning management system, you can get to it from where you already are. So in the same location, 48 hours from now, the recording of this session will be available. And then your face-to-face credits will be posted within 2 weeks of today's event. So that concludes our session, which is copyrighted in 2020 by the American College of Healthcare Executives, all rights reserved. Thank you, everyone, and have a great rest of the day and afternoon.
Thank you, everyone.
Thank you.